So our next speaker is Dr. Ian Steele, and we're always very honored to have him here. And if you haven't read his bio, please do. It's impressive enough that someone like me who's worked alongside him has always felt I don't have to do any research. I don't have to be an academic. Just working with Ian improves my reputation. And that's enough for me. So I think his latest, besides being the originator of, or the head researcher of the Ottawa ankle rules and going on from there, Canadian C-spine rules and on from there, he's now, what are you, the editor-in-chief of the Canadian
That's right. Yeah.
Journal of Emergency Medicine, right?
Yes.
Okay, so I'll let him speak for himself. Now, thank you, Ian.
Okay. But I'm no good at little microphones.
That's okay. Just clip it on to your belt. Or you can put it in your pocket too if you like.
Excellent. Okay, is this working? Good morning, everybody. It's a real treat to be here, and thanks for the nice intro, Christine. I've been talking at this conference like before some of you were born, way before some of you were born, so it's fun to get at least another crack at this. So today I'm talking about one of my favorite topics, which is acute atrial fibrillation, and in particular the new CAEP guidelines that were published last year. So I have one little potential conflict of interest to mention is that we have a CANET grant, Cardiac Arrhythmia Network, and that grant included some money from a private industry, Servier Corporation, and that was used to make the atrial fib app that I'm going to tell you about shortly. They make one of the 4 no-access out on the market, but I don't think you're going to see any bias in my talk. If you think you see something, let me know, please. Bunch of things I want to talk about, just to remind you what I mean when I talk about acute atrial fibrillation. And then, so we're going to go through in some detail the best practice checklist that was published in my favorite journal, CGEM, in the spring. And I'll show you how to get onto the app. And we're going to talk in particular how you stratify for stroke. And there's 2 risks. There's a short-term risk of stroke, and then there's a long-term risk of stroke. Just review how you use warfarin or any of the NOACs, the 4 NOACs that are out there in Canada, what you do with an unstable patient, how you avoid admitting these folks, because most do not need it, and then what kind of follow-up you should be arranging. Now, I'm more than happy to have comments or questions as we go along, except from Dr. Clark. But like if I say something that's so totally outrageous you can't stand it any longer, like just stand up. I don't mind. It'll make it more interesting, actually. I can take it. Okay, so what the heck is acute onset atrial fib or flutter? Is symptomatic, and it has generally started in the last 48 hours. That's the classic definition. And it can be the first time they have it, or it could be a repeat episode. But it's short-lived typically, to be distinguished from chronic or permanent atrial fibrillation. And traditionally, you could treat these patients with rate control and send them home on warfarin, or you could cardiovert them in the emergency department. And I think more and more Canadian emergency doctors are cardioverting in the ED, and that's what my bottom line message will be. At the same time, doing this safely and for sure preventing stroke. The CAEP guidelines strongly endorse rhythm control, aka cardioversion with drugs or shock, because it's much better for the patient. They get to go home almost immediately back to normal activities, as opposed to going home on a bunch of medication and coming back in a month. So they don't need rate control, and they may or may not need oral anticoagulation, depending on their age. It gets them out of your department quickly. There's no reason why such patients should be there more than 6 hours. And as I said, many parts of Canada, this is sort of standard of care. But I think depending on where you work, it may not be, or may be more challenging. How many of you work where you're like the only doctor on duty at a time? The whole audio. Okay. Right. Anyway, it can be done, I believe. And call me out if you think I'm a big city guy that thinks he knows it all. Okay. So the message is cardiovert yourself with drugs or shock. Do not call cardiology or medicine or whoever seems to help you with these. You don't need them. Don't order troponin. It'll just prolong the stay and drive you crazy. Try and get them out in 6 hours. And if they're CHAD65 positive, you'll have to prescribe oral anticoagulants. So these are generalizations, of course, but I think these are some of the messages I'm going to try to convince you on. So let's look at a case study, and this will help me kind of gauge a little bit where you're at right now in terms of acute atrial fibrillation. So this is a 67-year-old who presents with sudden onset of palpitations 6 hours ago. He feels a little weak, but he's not having chest pain or shortness of breath. He's never had this before, and in fact, he's a pretty healthy guy. But he does take aspirin and a statin, and you can see his heart rate is 140, blood pressure is up a little bit. ECG shows atrial fibrillation at around 140. So, having listened to me, you go ahead and give procainamide, 15 kilograms per, or 50 milligrams per kilogram over 30 minutes as a bolus, and the guy converts. Ta-da! So, what's his CHAD65 status? And this is a Canadian Cardiovascular Society classification that's been around for about 4 years now. So is he negative or positive? How many think he's negative? How many think he's positive? Okay, many of you probably never heard of this. And he's positive because he's over 65. It's a pretty simple rule, because most, there's a bunch of other stuff, and we'll come back to it, but if everybody over 65 has to get oral anticoagulants, that's just the way it goes. So let's say you have cardioverted this guy with procainamide. It doesn't matter if you do it with drugs or with shock. It's the same risk and impact in terms of stroke. So it doesn't really matter. If you think you're doing it with procainamide safer, it's not. They're both really safe. So here's a bunch of choices. Do you think you should be giving heparin, IV, or low molecular weight, just oral aspirin, or a whole bunch of nothing? So who would vote for A, or B, C, D, or E? All right, I think you don't need this lecture, so let's go for a coffee early. You're doing well. Okay, so he has a CHAD65 positive because he's over age 65. Okay, now what does the CCS say if you're going to prescribe oral anticoagulants to this fellow? Are you going to give the novel oral anticoagulants or warfarin? So they say, is this a true statement? Novel OACs are preferred. How many think it's a true statement? How many think it's a false statement? Okay, so you've probably had reps in your office, those of you that work in an office, haranguing you about all the choices, and now there's 4 for the NOACs. But anyway, the CCS believes that they are more effective. They work almost immediately, like within 2 hours. And they don't require that really annoying INR monitoring. And you just need to, suck it up and put a fake limited use code on the prescription. And in case you feel guilty about that, apparently everybody does it. I don't know. And the government understands that across the country. We're doing a trial to implement the new CAEP guidelines in a bunch of cities, 11 cities. The one's in blue, Ottawa's coordinating it, and we're trying to convince the doctors there to do what I'm trying to convince you to do and see if it helps get the patient home quickly and safely. And you'll see I don't have we only have one site in Ontario and none in Alberta, BC, because they all cardiovert already. So there's a lot of sites that don't, and these are like moderate to large hospitals. So these guidelines were published last May in CGEM, and they didn't come out anywhere. So I was the chair of the committee that created this best practices checklist for CAEP, and it was done by a committee that included academic and community hospital emergency docs, 3 cardiologists, and all kinds of behavioral scientists who thought they could help us change practice out there. I'm skeptical about that. We even had 2 patients as well. And what we did is we took the existing CCS guidelines that are updated every 2 years, and then we adapted it specifically as a how to do it checklist for emerge docs. And it's in both languages. And as I mentioned, it's adapted from the CCS guidelines, and 3 of the members of our panel, actually 4 members of the panel are also on the CCS guidelines panel, so there's significant overlap there. So here's the overall algorithm, and it's just like, I mean, I'm not going to apologize, I'm just trying to show you it can be a bit complicated, so our job is to make it easier for you and break it down. And the easiest way, though, is if you choose to download this app on your smartphone, and this is not commonly known. So a bonus for coming to this conference is you get access to this. So we're not publicizing it because we're mostly using this. So it's a web-based app, and if you have the patience to type that in your Google search or whatever, in either language, you should get our web-based app, which is pretty smooth and will give you quick overviews or the details of the checklist and all kinds of allied information. So don't tell your friends because it's still somewhat confidential, but you're welcome to use it. And we designed it, and this is what Servier helped to pay for, and I don't think you'll see any bias towards their particular drug, which I'm not going to necessarily talk about. But we designed it for our trial, so it's only being released at the sites, the 11 sites in our hospital, plus very special doctors that I talked to. Okay, so the first part of the checklist is like assessing risk and stratifying risk, and there's 2 big questions. One, is this actually primary AFib, or is it as an arrhythmia, or is it secondary to some medical cause? And second, is the patient unstable or not? And they're both very important, and our algorithm is a lot different from ACLS, which just gives you a very low bar to call unstable and shock. The ACLS is way off base on atrial fibrillation. Okay, so we're going to go through all these little steps, so don't fuss too much about it. And it's all on the app, actually. First question, of course, is the patient unstable? And I'll say this is super rare, and if they are, most of the time we're going to shock them, okay? Assuming that they're stable, are they high risk for short-term stroke? And these are the folks in the top bar there who have had onset more than 48 hours, or they don't know, which is sometimes the case, or they've had a recent stroke, or they have mechanical or rheumatic valve disease. This whole thing is non-valvular atrial fibrillation. And the third group are the low risk for short-term stroke, meaning by and large, they've come in less than 48 hours, or they're fully anticoagulated. So again, we'll go through all the little boxes in a minute. I'm just trying to set the scene here, the overview, as it were. Okay, so Christine says I'm getting on in years, and I have to check off things on my bucket list. So where was this bucket list? Africa, good. Certainly wasn't Canada. Where in Africa? Any takers? Anybody been there? You're all too young to be on your bucket list. Oh, you've been there. Okay, where? Exactly. Excellent. Tanzania, similar to Kenya, but nicer, safer. So just an amazing amount of cool stuff to see. the cheetah, my fellow baby boomers, like glamping, giraffes. This is like roughing it with hot and cold running showers and stuff, minibar. This is a leopard having, unfortunately, causing a bad day for this baby warthog. Okay. I had a nice picture of Zanzibar. I don't know where it went. That was the best picture. It was more cheerful than the last one. All right. So let's go in a little more detail about the question. One of the primary questions you got to figure out, you got a patient with rapid AF, and is it like paroxysmal AFib, or is it they're permanent AF, but they're sick with sepsis or bleeding or hypoxia or something, okay? PE, heart failure, ACS. These are possible. These are common causes of rapid AF, okay? And you really got to figure it out fairly quickly, because cardioverting them is the wrong thing to do and could make them way worse. Occasionally could even kill them, okay? So this is a big deal. So we have some tips that we, as a group, thought would help you. So when is it medical? Well, if it wasn't sudden onset, the patient doesn't have palpitations, they're already known to have permanent AF, and you can infer that by the fact they're on OACs, or old ECGs show that, but sometimes it takes some detective work because the nurse might have written down past medical history AF, but you don't know if that's permanent or they just had a few bouts of it in the past. They've never been cardioverted. So there's the rule of 150, which apparently is fairly good. And that means that if the heart rate is below 150, let's say like 130, it's more likely to be medical, because say an 85-year-old septic lady, it's very hard for her to muster a heart rate greater than 150 just from sepsis. So if it's over 150, that means it's more likely to be an arrhythmia. It's just a little tip. And of course, they have a fever, they're short of breath, or they're in severe pain, is more likely to be medical. So that is a big deal. And we talk about unstable, and basically we define stable as really unstable, like shock, severe chest pain and ST depression, or fulminant pulmonary edema. So these patients, like it's black and white. It's not like, are they slightly, you know, their blood pressure is like 101 or something. So these are unstable patients, and you have to deal with that obviously right away. But how you deal with it we'll come to shortly. Of all the patients we see, this is quite uncommon, 0.2%. Then those that are a high risk because the onset was over 48 hours, or it's unknown, or they had a stroke the last 6 months, or valvular. Again, that's not that common, and it's about 5%. And finally, the stable and low risk patients, they're the most common by far, okay? So I'd estimate 95%. So the hallmark of this is the onset is of less than 48 hours. In my experience, most patients know exactly when it started, and if they don't, then you have a problem. And if they don't, it's most often elderly patients who just started feeling weak 5 days ago, and they don't feel good, and it's a big surprise when they get to triage and their heart rate's noted to be 150. So there's some riders now where people are being more cautious if they have comorbidity with the CHAD65 criteria and they come in late. So actually most people show up in the first 12 hours. So there is a caution out there now that we endorse, is that if the patient comes in late, like more than 24 hours, and they have multiple CHADS 65 criteria, we'll go over those in a minute, then it's not safe to cardiovert. Don't do it. They need to be put on anticoagulants for at least 3 weeks. So that's important, and that's new in the CAEP guidelines and has just been reinforced by the latest CCS guidelines. So you may not have heard that one before. And then if they're on warfarin, there's always concern, is it therapeutic? And the INR, it's got to be therapeutic, and you have to believe they've been taking their stuff and that the levels have been therapeutic for at least 3 weeks. And NOACs are considered therapeutic if they've been compliant. So if they've been taking their NOAC every day for at least 3 weeks, then you can assume that they're safe, they're anticoagulated. Okay, so as I mentioned, going into paroxysmal atrial fib and then being unstable is quite uncommon. Almost never seen it. But certainly, if that's happening, you're best off to shock them. You can, if they're if they're holding their own, you can try rate control, particularly if you suspect they've been in it more than 48 hours. You have a problem there. But if they're really in bad shape, you got to shock them, and you might want to start the NOAC immediately. Okay, so what are we dealing with here? How many residents have we got? I could pick on. Former, recently residents? He said WPW, my recent resident. Well, 2 years ago. Okay, you guys good with that? This is a rapid ventricular pre-excitation, Wolff-Parkinson-White, and it's a scary pattern. You know, that is going to get your attention when the nurse brings you the ECG. So what are you going to do about it? Well, obviously, if they're unstable, just shock them. Actually, if they can be surprisingly stable, especially if they're young. You can give them procainamide. I wouldn't use ibutyl, tell you the truth, but procainamide would be fine. And there's a whole bunch of stuff that you must not give. So, okay, so this is anybody who works in any emergency in the country needs to be aware of this list. So do not give DIG, calcium channel blockers, beta blockers, adenosine, because it can cause the rate to actually get higher and the patient go into shock and arrest, and like that's just not what you want, especially when it's totally not necessary. So please don't give those drugs ever, ever, ever. Procainamide is like a tried and true. It's been around forever. It costs nothing, and it's pretty safe. Okay. So how about the high-risk patient then? They're over 48 hours or they just don't know. So you have to go with rate control there. Unless you have transesophageal echocardiography. And usually when I say that word, people just snicker at me because they don't have it. You have to be like at the Civic Hospital next to a heart institute to get it. You have to be at a big center. It's quite useful though, because it can tell you that the left atrium is free of clot and it's safe to go ahead and cardiovert, but most time you aren't going to have that. Okay, so there's a little nascent movement of emerge docs learning how to do this during cardiac arrest, and now I know the POCUS guys in our hospital are intent on world domination, so they may try to move into this area as well. I don't know, but so how do you rate control? Our studies have shown that most of us, especially in fancy big hospitals like where I work, we don't know how to rate control very well. Now in our hospital, of course, we always cardiovert with procainamide or shock. So maybe we're rusty, but we should know better how to rate control a patient if that's what they need. And generally the advice is if they're already on diltiazem or metoprolol, just go with the same type of agent, calcium channel blocker or beta blocker. Okay, so they're both first line for most patients. Calcium channel blockers, so diltiazem. So our mistake here is we don't give it aggressively enough. They should get all their 3 doses in the first hour, like quickly. Okay, and you should be starting oral. If they're not already on it, you should start oral right away. So that's the trick I wasn't aware of. And then you got to send them home on it. And we're recommending the doses I show there, 30 to 60 QID or extended release, either one. Like, because the few times I order, I have to look it up every single time. But now it's on the app. Ditto for metoprolol. You give the 3 doses within an hour, start oral, and send them home on 25 to 50, depending on their age and frailty and whatnot. So, DIG is still around. Back in my day, that was pretty much all we had for atrial fib. I know most of you don't remember those good old days, but it's still considered a strong second-line drug. It's not first-line because it's slow, but there are patients that can't tolerate beta blockers or calcium channel blockers, particularly if their pressure is soft, you know, around 100 or less, or they're in acute heart failure. You're not going to give diltiazem or metoprolol. So DIG is a really good drug, and we argued forever about the correct dosage because every reference you look up is different. But we think we came to this one here, load them with 0.25 to 0.5, and then repeat it every 4 to 6 hours to a total of 1.5 milligrams. And being careful for those that are in chronic renal failure. You have to get the heart rate down, okay? Just because you give the drug doesn't mean it's working. So you have to get their heart rate down to 100 before you send them home. And typically, you're going to want to get them up and do a little walk test in case the heart rate shoots back up to 140 again. So you really don't want them going home with a rapid heart rate because if it's not coming down, they can't go home. And, you know, that's when you might consult cardiology or medicine for advice, or you might go to the other agent, actually. You can switch from DILT to metoprolol if you have to, or go to DIG. Okay, so now we got the 95% group. These are considered stable and low risk. They're clearly under 48 hours, or they're fully anticoagulated. And so we're pushing rhythm control. Now, rate control is okay, but we just don't understand why you would use it. Okay, now some of our group thought, well, you have some really old patients and they don't really are not really symptomatic. Why not slow them down and send them home? But most of us think that most of the time you're far better off to do rhythm control, which is procainamide or shock. Okay, for all the reasons I told you, except if they come in after 24 hours and they have several CHAD65 criteria like hypertension or previous stroke or diabetes, or they're over 65, which they usually are if they got all that stuff. Okay, so if you're like many of my colleagues, they just want to shock them. Residents, that's their preference. It's more fun. So you can start with procainamide. You can start with shock. Doesn't really matter. My personal preference is to start with procainamide because then I can go see another patient and it's going to work over 50% of the time. And if it doesn't, then we just go quickly to shock. We just finished the RAF2 trial, which is comparing a shock first strategy versus procainamide first strategy. And if you come to CAEP, I'll be presenting the results. This is a randomized trial of 400 pages that took us like 3.5 years to complete, but I will. And we'll also tell you whether which pad position is better, anterolateral or AP. And I see some of my colleagues here, and thank you all for enrolling patients in our RAF2 trial. Okay, so don't give rate control if you're going for rhythm control. It's just a waste of time. You know, you can like dilly-dally for hours, but there's no advantage to it. None whatsoever. So just get on with it. Procainamide or shock them. Okay, so we're touting procainamide, 15 milligrams per kilogram in 500 of saline over 30 to 60 minutes. And in our trial, we did 30 minutes. Occasionally, the patient will get a bit hypotensive and you have to interrupt the infusion. That's why we put it in 500 of saline. It's not recommended if the blood pressure is low to begin with or they have a really, really long QTC. If the pressure does drop, then just stop it for 15, 20 minutes, give them another bolus of fluid, and usually you can carry on. Amiodarone is not recommended, and my residents come back from ICU and they all want to use amiodarone because it may or may not work in those patients in the ICU, but they're different than our patients, completely different. Ours are usually don't have a lot of comorbidity going on at the same time. And it is slow as molasses in Ottawa, January. So just don't do it. Okay, you have lots of other stuff. Vernaculant is a fairly new agent that's come on the market in the last year and a half, and it's being marketed in Canada. Ibutylide is an option. We don't like it because it can cause torsade de pointe 2 to 3% of the time. Propafenone and flecainide can be given orally, but we don't like them either because they're quite slow and you have to monitor the patient for like 12 hours after for safety reasons. So by and large, first choice would be procainamide. Okay. As for cardioversion, obviously it's a manpower issue if you're in a small hospital. You know, you need a minimum of the doctor and 2 other people. One to help you with the drugs and document, and one to keep an eye on the airway and hypoxia. So in our hospital, we're lucky we can have an RT and a nurse. And I think our policy is to have 2 doctors there, but like second-year med student will suffice because it's not really rocket science. So how many of you work in a place where you absolutely have to have 2 doctors present to cardioversion? Like that's the law. Oh, okay, that's promising. Good. Okay, the guys from TOH didn't stick up their hand, but cool. I'm going around preaching to these sites where they never cardiovert, like in Montreal, Quebec City, and Moncton, New Brunswick, and whatnot. And I try to draw a parallel to reducing a shoulder. Like nobody's afraid of reducing a shoulder, and this is actually easier than reducing a shoulder. So you got to sedate the patient and shock them, and you're done. There's no like pulling and swearing. And you never have to swear where you cardiovert. Unless it doesn't work, then it's like, but that's rare. Okay, so, you know, most sites use fentanyl, propofol, but it's whatever you do to sedate for a shoulder, do the same thing. So it doesn't matter if you do anterolateral, anteroposterior, and I'm pretty sure our study shows they're both equally good. So anterolateral is a little more convenient. What do you do if it doesn't work? So you always start at max, which is around 200. Max on the machine, just start with that. Don't start low and work your way up because you only want to shock them once or the propofol wear off and then you have to keep resedating them. So start at 200. It doesn't matter. So what if it doesn't work? What do you do? So obviously mistakes can be like putting it in the sternum instead of under the clavicle or putting on top of a large breast. You got to get under the breast. And a trick that I learned from the cardiologist is that the paddle, so it's almost what, so now we typically use pads and no paddles. But if you're having trouble, grab those old paddles and push down hard on the pads. And the extra pressure and contact may help it work. If you've tried this 3 times, you can go to anteroposterior. Try the other one. So those are some tricks if it doesn't work, because it's super annoying when they're resistant. Okay, and we just sent them home, like within 30 minutes if we've used propofol. You know, if you use phenobarb, probably they'll be around a lot longer, but I don't think you do that anymore. They never even heard of phenobarb, but it's still around. Okay. Send them home. So now we're moving on to section C, which is how do you prevent them from having a stroke next month or next year? Because that's still kind of our responsibility. And the modern thinking is that one episode of paroxysmal atrial fib puts you at risk of stroke long term. And that's why for the last 5 years, the CCS has strongly advocated that paroxysmal atrial fib be treated with long-term anticoagulants if they're CHAD 65 positive. So what the heck does that mean? Okay. So here's the algorithm. And it's pretty simple because most of them are going to be 65. That's automatic yes. If they're not over 65, but they've had the stroke, hypertension, heart failure, diabetes, the traditional CHADS 2 risk factors, they need oral anticoagulation. If they don't have any of those, they might need ASA if they have coronary artery disease or peripheral arterial disease. But the fact is, anybody with coronary artery disease is already on aspirin anyway. I'd be shocked if they weren't, so to speak. And then everybody else doesn't need to be put on anything. And so part of the messaging is that it's really, we'd like you to take on this task of prescribing the OAC when they go home if they're CHAD65 positive. We don't know how long it would take for them to see a specialist. We're afraid the family doctors may or may not be totally aware of this. So the safest thing is for you to write the prescription, which I know creeps out a lot of emerge docs. If you do family medicine, you're used to that. But if you're pure emergency medicine, you're not used to prescribing a lot of OACs, so it kind of creeps you out. Too bad. Okay. So the CCS recommends NOACs, and because they believe they're more effective, because you don't have to do INR monitoring. They're expensive, so you're typically going to write an LU code for them. However, mechanical valve, rheumatic mitral stenosis, severe renal impairment are contraindications. You have to use warfarin for those guys. Okay, now you're supposed to consider bleeding risk, which would be probably very high fall risk, very high. NSAIDs, heavy drinking, so Eric Clark, for example, gets the alkies to sign a thing that they won't drink anymore, and then he hands it to them. I don't know why he's shaking his head, but okay. You want me to pick on somebody else there? Okay. Anyway, if they've had recent PCI, then you got to talk to cardiologists about what to do with their antiplatelet agents. It gets a little heavy there. Okay, but you still got to do it. Okay, now if they're negative, but they have, what was that? Okay, that says 9 minutes.
Well, that's we have time for questions.
Oh yeah. Oh, I was going to blather on. Okay, so if they're CHAD65 negative, but they have coronary artery disease or arterial disease, they should be on aspirin if they aren't already. Now, if you are lucky and you get a TEE-guided cardioversion, then you're supposed to start NOAC for 4 weeks, regardless of anything else. Okay, anyway, there's details there. Oh yeah, the second sentence, I was supposed to put that in there. So this era of shared decision making. Now, if you're in family medicine, you're probably more used to shared decision making. Emerge docs are generally pretty paternalistic because we know what's best for you, and we're too rushed to spend adequate time explaining. We hope to develop a quickly used decision aid to help patients, but and there's handouts to be given that Thrombosis Canada has created on what is OAC and why you're on it and what to watch for to help explain it to the patient. And then they obviously need follow-up with their own doctor as well as a cardiologist at some point in their life. Okay, so we recommend the Thrombosis Canada app, which is also free. Certainly our app is very free. You just need to know the secret link. Okay. And NOACs don't give in pregnancy or breastfeeding. Don't use with severe renal failure in the limited use codes that are used a lot across the country. And there they are. There's 4 of them. So if you're pure emerge, don't work in a family medicine office or other clinic, my advice is to kind of get used to one of them, And like if you were to see if you work in Ottawa and you see what patients are on, well, they're on all of them. So it's not like the cardiologists have all agreed that one is better than the other. They all have pros and cons, and they have little quirky dosage things, which I won't bore you with, but you should You can look up our app or the thrombosis scan app if you have more patience, and just pick one and get used to it. Okay, if you have to go with warfarin for a variety of reasons, this is how you're supposed to do it. Curiously, if you're frail, low weight, or of Asian descent, you don't tolerate it so well. I didn't know that, especially the Asian part. That's what they recommend. Okay, so disposition and follow-up. This is what it looked like when I started working at the Civic Hospital back in 1924 when it was first built. It was all shiny. So most of the time, don't admit these folks. It's just like not a kindness, and it's unnecessary and wasteful to admit them. Just send them home. Unless you just can't get the rate down or their trope went up, but you won't know that because you didn't order a trope, please. Most of these patients shouldn't have a trope because it's going to go up slightly, like that much. And as soon as you see that much, you got to do it again, and it'll be there forever. So unless you really believe they're having crushing chest pain with ST depression, don't order a trope. Okay, and that's in the guidelines. It's approved. Or they have severe heart failure that's not really getting better. That's fair game too. And then there's all kinds of weird stuff that hopefully you don't have to deal with a lot. It's like congenital heart disease and other things that might require you to talk to cardiologists. Okay, so the follow-up checklist. If it's warfarin, you need INR monitoring. We'd like them to see a family doctor in a week, okay? Especially if it's on warfarin or new rate control meds. That would be really nice if they could see their family doctor in a week. Cardiology and internal medicine, whatever you have, is not necessary for 4 to 6 weeks, okay? Like some hospitals have really great follow-up for this. TOH is going to be 6 weeks probably before they can get into a cardiologist. And give them handouts. You can use the ones from Thrombosis Canada, et cetera, check, check, check. Do not give antiarrhythmic agents like metoprolol, sotalol, amiodarone, propafenol. Like, that's not our job. Just don't do it. And most don't work, or they're pretty risky. Like amiodarone could cause severe life-threatening pulmonary fibrosis. So it's not our job to prescribe that kind of stuff. They can wait till they see a cardiologist. And once they're back in sinus rhythm, the only decision is whether to put them on a NOAC. You certainly don't put them on diltiazem or beta blocker. Okay, so once again, this app is available. And important message. How much time now?
Questions. Now you have time for questions.
Okay. Ta-da. Okay, so I'm happy. You don't look too riled up, but I don't think so. All right.
Is there a button on it?
Oh, okay.
Hello? Oh, there we go.
Oh, yeah.
Hi, Andre Touchburn from Moncton.
Aha.
Yeah.
Were you there when I went to Moncton?
I don't believe so.
No, I was at Georges Dumont. I don't know which hospital.
So I've worked at both hospitals in Moncton, and I'd say that we do cardiovert a lot.
Yeah.
Actually, my question is, how much is too much? How many times can you cardiovert someone before you give up?
You write them off. Yeah, well, that's a good question. And certainly doctors get frustrated with seeing them coming back. And so the repeaters should be seeing a cardiologist who makes that call.
I mean, with your attempt in the emergency department, if they don't respond to the first shock, how many times?
Oh, I'm sorry. Yeah. I thought you meant like if they've come back 5 times in a year, like you just give up. I thought that's what you meant. No. So it depends how stubborn you are. I'd probably go about 5 times myself. You know, maybe 3 in the first position, and then a couple in the other, but I'd be doing the pressing thing and make absolutely sure you're at the max level. And, you know, it gets frustrating.
And you would increase the energy if you're repeating?
Well, we like you to start at the maximum that's on the machine. Like your first shock should be the maximum.
Okay. All right.
Is that
Yep.
okay?
Thanks.
Yeah, okay. Yes.
Just a follow-up to that question, if it was unsuccessful, would you then go to procainamide, or would you talk with?
Well, once the trial is published, you will know the answer to that. There's a slightly higher rate of overall success if they got procainamide. So that is an option. You know, if you didn't give it to begin with, which is what I would do. But you could do that. Yeah. Like, you know, go for aside for have a smoke and hang the procainamide while you calm down, and then hopefully it'll work. And if it still does, and then you can shock them again, because there's some evidence that procainamide itself might not work, but it may facilitate the electric shock. You know, or you know, it depends where you are and how busy you are, and whether you're just going to call cardiology and let them take it off your hands. You know, it's a good question. Can you guys hear him? Oh, you're on YouTube, man. Like, yikes.
So if a patient has...
Did I know that? We're on YouTube?
If a patient has their own cardiologist...
Christine?
They've been prescribed a oral, like flecainide, Solval, one of these.
Pill in the pocket thing,
Yep,
you mean?
and they've taken it before they come in. Are you still giving the procainamide?
Yeah. Not if it's propafenone. So I take that back. I would just shock them. Yeah. If they took what are the other drugs you've seen?
Sotalol.
Yeah. Geez, I thought that was like in the dustbin somewhere.
Now and then.
But you see patients say, so they're told to take it.
Yeah, they've been instructed.
Okay, that's not recommended by anybody, but anyway, just shock them. Yeah, you can't go wrong. Yeah, so propafenone, there may be some interaction with procainamide.
The patients, you gave the unstable pathway.
Yeah.
So if I've got the 45-year-old guy, crushing chest pain, diaphoretic, and is in rapid AFib, has ST elevations, inferior leads, reciprocal changes, I'm 30 minutes, say, from OHI.
Yeah. Do
I stop and shock, or I
absolutely
just ship him out?
Yeah, you got to get his heart rate down. It's going to make, it might even make the MI go away. Then he can just go home. No, I would strongly recommend you shock and get them out of that rhythm. Okay, yeah, that doesn't happen often, fortunately. Yes. Oh, would you mind the microphone thing? Well, I don't know if YouTube. It says people are going to listen online, or they are listening online, apparently. Out there, did I know this? Christine.
Okay, hi. So why the age of 65? What happens at 65?
You just fall apart. Like
no, but what's the percentage of change? And there's also something called atrial fib load. So if you only have one episode, why should you have a clot in your atrium? And why do you have to be treated with NOACs if you only have one episode?
The cardiologists have evaluated all the evidence. I take them on their word, but they found that the CHADS-2 score was 75, but the evidence has brought it down to 65. That it significantly increases your risk. I'm sorry I can't give you the exact percent, but it definitely puts you at a higher risk for having a stroke sometime. And so these are, like this has been out for 5 years now. And then your other question is, and I know where you're coming from, like the guy just has one episode and man, I got to prescribe a NOAC. Well, those are, that's the standard of care in this country, unfortunately, or fortunately. So that's all I can tell you. Sorry. Dr. Ho.
Thank you, Dr. Stiell. With the presentation, you told us to exercise caution 24, 48 hours with CHADS 2 or more.
Yeah.
The CCS guidelines say 12.
Yeah.
How do we rational? Like, what do we do? And
Well,
are we defensible to do
here's
it?
the only one that has read the CCS guidelines here. Anybody else read the 2018? My story's like. Okay, so I really don't want to go most of what they said because it's under dispute over interpretation of the grade guidelines, but the 12 hours is probably where CAEP's going to go. All right, so our printed guidelines say 24 hours, but I think we're just to be consistent. This is all based on a big Finnish registry that's been studied and published many times in the last 6 years, where they found two things: that those that have a stroke after cardioversion have multiple CHADS 65 criteria, and secondly, they came in late. Okay, so if they have several CHADS 65 criteria and they come in after 12 hours, then don't shock them. So thanks for that clarification. I'll have to update my slides or get a TEE, but good luck to you doing that.
I'm not kicking Dr. Stiell off because I think if people have questions, that's important. So you're welcome to keep asking him questions. But it is officially time that if you want to go for your networking break, there's no shame in getting up and walking out.
So I get a coffee too?
No, you have to see if there's any more questions.
Oh, like stand here. Well,
yeah.
Okay. But go get your coffee. Like, you know, I'll step down here and you can come and talk to me if you want. Or
okay.
yeah.
That's good.
Yeah. Okay. Thanks.